emergency medicine. Let us discuss about one of the important topics in emergency medicine, angina. Here we are discussing a type of angina, that is variant angina or incidental angina. Slightly different from routine anginas, but the presentation will be almost similar. This type of angina, that is incidental angina or vasospastic angina, that occurs mainly due to the coronary blood vessel spasm. So there will be an hyperactivity in the coronary blood vessel. So that is produced due to various reasons, including some allergic reasons, and that produces severe angina. It is characterized by repeated episodes of rest angina and transient ST elevation during attack. That is very important. So normally ST elevations are not seen during angina, but it is seen in patients who is having myocardial infarction. Here in angina itself, patient is developing ST elevation. It is the problem occurring due to complete spasm of blood vessels, and during that spasm, sometimes blood vessels can completely can cut off from the distal part, and that may produce something like myocardial infarction. And since it is reversible, after some time you don't see the elevation of cardiac enzymes like in myocardial infarction. So during the chest pain, if you take an ECG, then you can see ST elevation during the acute episodes. But after sometimes, once the angina is relieved by drugs or spontaneously, it can also reverse that. Now here you can see the vasospasm occurring here. Vasospasm occurring. So what is the difference between angina, normal angina? You have a vasospasm with a rate that produces some reduced blood vessel. Myocardial infarction, that rate can rupture and block the coronary completely. In vasospastic angina, actually the occlusion is complete. It is like this. Due to spasm, the occlusion is complete. But after some time, this can revert back to normal because after taking just rest or after taking subsequent nitrate or after taking diltiazem or whatever, this can reverse back. Calcium channel blocker or this can revert it back. So you can see here spasm, and spasm completely blocks the rest of the one side to that side. Patient can have symptoms of angina during that. So some patients can have fixed obstruction, and on top of that, patient is developing spasm. One of the important risk factors for vasospastic angina is smoking. So that is the risk factor for everyone. Like you can have Reynolds syndrome, Reynolds phenomenon, migraine episodes can be there, aspirin-induced asthma can be there. So it all related to some sort of allergy or vascular changes in your body. There are some drugs like recreational drugs like ephedrine, cocaine, marijuana, alcohol, butane, sumatriptan. That's a drug used in migraine prophylaxis or migraine treatment. That also can sometimes trigger the angina. Amphetamine. So all recreational drugs can present with acute myocardial infarction like features. Some patients it can be real myocardial infarction, some patients it can be vasospastic angina. So many patients with hyperventilation also precipitate vasospastic angina. This is also very common nowadays. You can see patients come with severe breathlessness, tachycardia. So during that episode, patient can also have angina, but after sometimes it can reverse. That is a type of vasospastic angina. In that condition, we are seeing. Exercise, normally they don't produce vasospasm in this type of angina because exercise normally dilate the blood vessel including coronaries, but if there is an existing lesion, then that can produce unstable angina, but exercise don't produce vasospastic angina. Incidents are very, very rare. Some conditions like allergic vasospastic angina, that also sometimes during allergic episodes, patient can have features of vasospastic angina, and some inflammatory markers, eosinophilia, IgE, all these things can also be elevated. Now, what happened to CKMB in all types of coronary syndrome? You know that whenever there is myocardial infarction, CKMB, troponin, all are elevated. unstable angina, they are not elevated. So that is the main difference between myocardial infarction to unstable angina. Myocardial infarction, whether it is ST elevation or ST depression, deep T valve inversion, if cardiac enzymes are elevated, they are myocardial infarction. Whatever may be the change, if cardiac enzymes are not elevated, then it is angina. So here, in vasospastic angina, you can see minimal amount of elevation in the CKMP property because we have already seen the unstable angina. The problem is there is partial obstruction during the exercise. The demand is more, so supply is less. But whereas in myocardial infarction, it is complete block. Then it produces damage to the myocardium. That produces elevation in the CKMP and troponin or troponin. Here the problem is for a short duration of time, there is complete blood supply, there is complete disruption in the blood supply of the pulmonaries. So the cardiac muscles will get less blood supply for a transient period of time. So that also mildly elevates this cardiac enzyme, not like myocardial infarction. So there can be sometimes elevation of CKMB or troponin, but it is very, very minimal. TMT, you can get TMT changes sometimes during this exercise, but most of the time TMT may not show the changes at all in some patients, because exercise normally will not trigger this type of vasospastic angina, whereas exercise triggers the unstable angina. Other types of angina can be triggered by exercise, but even then some patients you can get ST segment elevation during TMT test. So 10 to 30% of patients can have similar things. Here what you are seeing is patient has come with acute chest pain. You can see the ST elevation B2, B3, B4, B5, B6. And during that period you can make a diagnosis of antiviral myocardial infarction. But what happens after giving sublingual nitrate or AETCM, after sometimes this ischemic changes can be completely reverted back to normal. And if you see the serial troponin I or troponin T or CKMB, you may get a mild elevation in the troponin I and troponin T or CKMB, but the serial test may not show any serial elevation in this lab investigations. Now, coronary angiography normally demonstrates coronary vasospasm during injection of drugs like vasoconstrictor medications that can produce this type of changes. You can visibly see in coronary angiogram, but otherwise mostly they are normal. Some patients you can see atherosclerotic plaques. Some patients, but we cannot tell that atherosclerotic changes are producing this problem. Existing atherosclerotic change, if the patient develops spasm, the pain will be more severe, intense pain. So some patients can have autonomic nervous system involvement during vasospasm. So that can also see in some patients. Sympathetic tone can be increased, vagal tone can be increased. So they can have bradycardia or tachycardia depending on the tone. Now, some arrhythmias can be very potentially fatal to the patient. That also can happen. Smoking should be stopped in all these patients because smoking is one of the important triggers in vasospastic angina. So we have to tell the patient or counsel the patient to stop the smoking. Now, what are the treatment? How can we treat this patient in emergency room? So whenever you have severe chest pain, like any other patients, you have to take care of airway, breathing, circulation. Some patients can have sometimes pulmonary edema, tachyarrhythmia, or should be corrected. If desaturation occurs, we have to give oxygen because when there is vasospasm, even if like the patient is breathing properly, sometimes desaturation occurs because of the cardiac failure. So that should be corrected. Proper cushion, oxygen, all these things should be given. Now, nitrates and calcium channel blockers are the drugs of choice in this condition. Nitrates, you know that it dilates the pulmonary. Even calcium channel blockers also dilates the pulmonary. So they are effective drugs in these two conditions. They are effective drugs in this condition. And statin should be given for all patients who is, whether they have atherosclerosis or whatever, even if it is not that we have started statins, because unless until we do a proper angiogram study, we will not be knowing what is happening inside the body. So you can use statins during acute episode, and like other conditions where there is angina, one of the important drug we give is propranolol or beta blocker. But here it can produce some like exacerbation in the vasospasm. So that should be avoided. So the major change between the other types of angina to vasospastic angina, beta blockers are not first line drugs. Here it is nitrates or calcium channel blockers. Aspirin should be started in patients who is having any type of angina, but here we have to be very careful. Some patients it can produce aggravation of symptoms, so we have to be very careful. Many patients can already have migraine with vasospastic angina. So in that type of patients, we have to avoid smart drugs. So that also we should keep in mind. Some drugs should be avoided. Some drugs we should use with caution. And drugs commonly, the important drugs used in vasospastic angina is nitrates, calcium channel blockers, and statins. So any angina, you can do nitrates, calcium channel blockers, and statins. But most of the other types of anginas like myocardial infarction or unstable angina, beta blockers are safe. But here it is not that safe. We should try to avoid this. And there is a criteria called as Pavadis criteria. So it's a diagnostic criteria for vasospastic angina. There are 3 core elements establishing the diagnosis of vasospastic angina, including nitrate responsive angina, transient ischemic electrocardiographic changes, that is ECG, ST elevation, and angiographic evidence of coronary artery spasm. So important 3 criteria should be there to make a diagnosis of vasospastic angina. This criteria is called as Pavadis criteria. Now we have discussed about one of the important type of angina. It's not very common. It's a type of angina which can mimic acute myocardial infarction. The main difference between acute myocardial infarction is elevation of the CKMT or troponin T or I, and the serial elevation of these investigations also are very important. Whereas in vasospastic angina, it occurs due to vasospasm, so there may be mild elevation of cardiac enzymes, but there is no major elevation of cardiac enzymes, or there is no serial elevation of cardiac enzymes. And comparing with other types of angina, that is also very important. Other types of angina, the major problem is atheromagnetic plaque and the demand supply mismatch. The beta blockers can be given safely in unstable angina, but they are not preferred drug in vasospastic angina. Aspirin is safe in unstable angina. Here it is not that safe. Here the main 2 drugs are nitrates and diltiazem, or meloxicam also, but commonly we use diltiazem. That is what a coronary vasodilator power.